everyone. I am Dr. Prasad, Consultant Radiologist in Vijaya Diagnostic Center, Hyderabad. On behalf of Vijaya Diagnostic, I welcome you all for the VDC webinar series, where we have interaction between clinicians and radiologists for mutual enhancement of knowledge and for better patient management and care. Today's topic of discussion is role of cardiac MRI in hypertrophic cardiomyopathy. As we all know, MRI plays a crucial role in the diagnosis, prognosis, as well as management. Most of the times beforehand only we have a idea of about the diagnosis, which comes through echo, which is done before sending the patient to MR. But at times there are also presentations where echo may not pick up these findings beforehand. All this and more we will learn today. We will listen and learn more about these things from our expert panelists today. And it is truly an honor and privilege for me to introduce our expert panelists for today. About the introduction, our first panelist, who is chief guest today, is a cardiologist, Dr. Sagar Bhuyar, sir. Sir is a senior intervention cardiologist and assistant professor in Kamineni Institute of Medical Sciences and Research Center, LB Nagar, Hyderabad. And sir has experience of more than 10 years in cardiology. Sir's expertise include coronary angiography and angioplasty, peripheral interventions, balloon valvoplasty, pacemaker implantation, transesophageal echocardiography, adult and congenital echocardiography. Sir holds certificates of Fellow of American College of Cardiology, Fellow of European Society of Cardiology, Member of Cardiology Society of India. Sir has done MBBS from Dr. PDM Medical College, Amaravati, Maharashtra, MD in Intensive Care from Indira Gandhi Government Medical College, Nagpur, Maharashtra, DNB in Cardiology from New Delhi. Sir has a lot of research work on his name. Few of the salient ones include clinical follow-up of zotarolimous eluting agent as compared to bare metal stents in Indian population, cholinergic atrial fibrillation following subcutaneous absorption of organophosphate compound. Welcome, sir. Welcome to our webinar, and we thank you for accepting and gracing our webinar despite your busy schedule. Thank you, sir. Our second panelist for today is radiologist Dr. Deepak B, sir. Sir is a senior consultant radiologist in Vijaya Diagnostic Center, Himayat Nagar branch, Hyderabad. Sir has work experience of more than 12 years and done MBBS from St. John's Medical College, Bangalore. Sir has done MD and DMRD from Trivandrum Medical College, Kerala. Has a degree of DNP in radiology and has international degrees like European Diploma in Radiology, FRCR from UK. Sir is certified in coronary CT and cardiac MRI and has special interest in cardiovascular radiology, breast and prostate imaging, and has delivered several talks under aegis of IRI Telangana chapter. And sir has authorized textbook chapter on temporal bone imaging. Welcome, sir. Now I would request our chief guest, sir, Dr. Sagar, sir, to share his clinical experience about patients with hypertrophic cardiomyopathy and what are the challenges you face while seeing these patients, and what are your expectations from radiologists when you send these patients for cardiac MRI. Over to you, sir.
Thank you very much for inviting me and my warm introduction. And thank you, Dr. Krishnamon and Prasad sir, for inviting me for today's talk. It's a very important thing, I think, because now we have to change with the time, because previously we used to rely on the echocardiogram for the diagnosis and the decision making in hypertrophic cardiomyopathy. And all of us know hypertrophic cardiomyopathy is not a benign condition. There is a very high risk of sudden cardiac death, and proper diagnosis and assessment of the LVOT obstruction and type of cardiomyopathy and selection of the treatment, whether it is medical, ICD or surgical treatment or alcohol ablation, will definitely improve the survival in patient with hypertrophic cardiomyopathy. And all of us know that echocardiography was the gold standard. But if you see in last 10 years, I think the MRI has definitely changed the field of cardiology. And if you see in coronary artery disease and diagnosing the hibernating myocardium, aneurysm, the anatomy of the left ventricle, then typing and confirm the diagnosis of various type of cardiomyopathies like non-compaction, arrhythmogenic right ventricular dysplasia, and so many conditions with the MRI has definitely changed the outcome, like sarcoidosis, then intramyocardial tuberculosis. We cannot diagnose on the echo and any other modality. So MRI has definitely changed the diagnosis and the treatment option in the field of cardiology. And if you see the hypertrophic cardiomyopathy, it is not a single entity. There are so many overlaps, because sometimes we misdiagnose on the echo, like hypertensive heart disease, we misdiagnose as cardiomyopathy, or sometimes there's a Fabry's disease, athlete's heart, and sometimes infiltrative cardiomyopathy. That is very important. Many a time I see the many restrictive infiltrative cardiomyopathy misdiagnosed as hypertrophic cardiomyopathy, and we are treating them in that line and exposing the patient of risk of sudden cardiac death. And we are not categorizing, because sudden cardiac death risk is different in a different patient with hypertrophic cardiomyopathy, and the assessment of sudden cardiac death is the most important thing in survival and improve the survival in patient with HOCM. So MRI has role definitely in confirmation of the diagnosis. That means you have to rule out the other thing. So whether your diagnosis is right or not, that is important. So it is hypertrophic cardiomyopathy. We can see only after the CMR. The second thing is how much is the risk of sudden cardiac death. That means how aggressively we should be. That means the medical treatment, or you want to introduce ICD, and you have to take the decision of surgical or alcohol ablation based on the CMR and your angiographic finding. And sometimes there is an endomyocardial contrast echocardiography to select the patient for alcohol ablation. So CMR has definite role in not only in diagnosis, but selection of the treatment modality in that particular individual. And if at all you have done some treatment like surgery or alcohol ablation, then post procedure also we have to see how much is the success rate of those procedure, how much decrease in the gradient, and how much change in the thickness, and exactly in which area, and what is the infarct size if at all you have done the alcohol extraction, and whether that patient is having risk of any scar VT or not, that we can diagnose on the CMR. So definitely CMR has revolutionized in HOCM. If you see 5-6 years back, we are not doing any MRI in patient with HOCM, and just blindly we are treating them either with medicine or dual chamber pacemaker or ICD, or selecting them for surgery. But nowadays, I think after the detailed echocardiography, CMR is must before proceeding for any decision, whether it is medical or surgical or need of ICD, particularly to prevent the sudden cardiac death. So I think definitely the CMR is a very important modality, and many things the cardiologists want from the radiologist is, first thing is confirmation of my clinical and echocardiographic diagnosis, whether it is really a HOCM or not. Second, what is the type of HOCM? It is a sigmoid HOCM, or there is a reverse pattern, sometimes curve like hypertrophy, sometimes there's a neutral hypertrophy, sometimes there's apical hypertrophy, and many a time the ECG shows LVH and people will give normal echo, and because the apical area is the most missed thing on the echo, and MRI we can see more better. So the dose-TV inversion what we see on the ECG is seen apical hypertrophy on the MRI, but echo I think sometimes we miss in a hurry if we do it, and sometimes apical area is not clearly visualized in echocardiogram. Second thing is sometimes the ECG and the echo doesn't correlate. Definitely that time also the CMR is very much useful. Then another important thing in CMR is the intracardiac masses and thrombus differentiation. And if there is any infiltration, what type of infiltration? If there are scar, whether there are ischemic scar, infarcted scar, subendocardial scar, mid-myocardial scar, subepicardial scar. So that will definitely tell you about the etiology of the scar, and how much is the scar, particularly in HOCM, how many percentage and how many number of scars. So which patients are having higher risk of sudden cardiac death, we can stratify. And if you select those patients for the ICD and all, definitely we can prevent sudden cardiac death and improve the survival. So I think with this clinical input, I will request Dr. Deepak to proceed with his talk on what is the exact role of CMR in HOCM in diagnosis, then identifying the risk of sudden cardiac death, and post-procedure improvement in the gradient or SAM or whatever, what we will not see on the echo. That is a very important thing, that because most of the thing we see on the echo, but some of the thing we see only on MR, we cannot see on the echo. And I will see the imaging. In imaging, if you compare MR with other imaging modality, the MR is the only modality, I think there we see both physiology and the anatomy. In CT, we see only anatomy, not a physiology. That is the advantage of CMR over the other imaging. And it has now coming to the LV function and SAM and other thing. It scores nowadays superior to echocardiogram, because echocardiogram most of the time is operator dependent, but CMR definitely it give more inputs in terms of LV function, which patient is going to deteriorate and in the future, because HOCM ultimately it goes toward LV failure, LV dysfunction, that we can pick up early on the MR as compared to echocardiogram. So thank you very much again, and I request Dr. Deepak to proceed.
Thank you, sir.
Thank you, sir. Thank you very much for the clinical input, sir. It was really a wonderful input from your side, and it increased the radiologist knowledge as a radiologist. And Deepak, sir, now I request you to kindly start your presentation, sir.
Yes, sir. I hope you're all able to see my screen.
Yes,
So
sir, we can see.
thank you. Yes, sir. Thank you, Dr. J. Prasad sir, for this wonderful, uh, topic first of all, and for the kind introduction. I'd also like to thank Dr. Sagar sir for this excellent input he's given us in a clinician's perspective, what we're expected to see and what the advantages of MRI in the diagnosis of hypertrophic cardiomyopathy is. So let's straight away go into the topic. I have no relevant disclosures, and there's been fair usage of copyrighted material in this particular presentation. The objectives of today's talk is going to be centered only on hypertrophic cardiomyopathy, the role of cardiac MRI. So what we're going to see in different sections, we're going to first see the phenotypes of hypertrophic cardiomyopathy. We're going to see how the cardiac MRI helps us in treatment, the diagnosis and follow-up in different patients. And also we're going to see some case examples, and we're going to briefly discuss and touch upon the differentials of hypertrophic cardiomyopathy. So coming to the disease per se, it is the most common inheritable genetic cardiomyopathy with an estimated prevalence of 1 is to 500. It's a big number, and most commonly it shows autosomal dominant inheritance pattern. So basically it is a disease of the cardiac sarcomere or a cardiac myocyte, which is the cardiac muscle. What happens in this disease is there is disproportionate hypertrophy or thickening of the heart muscle, that is cardiac myocardium. Okay, so in this, by definition, the LV, left ventricular wall thickness, more than 15 mm, which cannot be explained by other cardiac and extracardiac causes, is defined as hypertrophic cardiomyopathy. And also there is a ratio of septal to the inferior LV myocardium of more than 1.5 is considered diagnostic of hypertrophic cardiomyopathy. Usually the patients present in varied type of clinical presentations with this condition. They can be totally asymptomatic, or they can have dyspnea, orthopnea, angina, syncope, pre-syncope, and also sudden cardiac death. This is the most important situation what a clinician and a radiologist will be looking at. This is sudden cardiac death. In fact, hypertrophic cardiomyopathy is one of the most common causes of sudden cardiac death in young individuals and athletes mainly. So that is the reason this particular topic has been given much importance with regards to medical care. Now, how is the if a patient has a hypertrophic cardiomyopathy, how is it diagnosed usually? That is usually the diagnosis is made on the basis of echocardiogram, that is ECG and echocardiogram. When the patient goes to the cardiologist, the initial diagnosis is based on these two modalities. So what echocardiogram does is it firstly gives us the confirms the diagnosis, gives us what type of hypertrophic cardiomyopathy it can be, that is the phenotype, and also it gives a bit of extended severity of LVOT obstruction, mid-cavity gradients, and also systolic anterior motion of mitral valve leaflet, which is typically happens in hypertrophic obstructive cardiomyopathy. So all this information we get in echocardiogram. So when we get all this information in echocardiogram, what is the need for cardiac MRI? And that is what we are going to focus in today's talk. What cardiac MRI does is it firstly confirms the diagnosis, gives a very exact phenotype of what the hypertrophic cardiomyopathy can be, gives us a risk stratification because there is a risk of sudden cardiac death. So we need to identify the negative or poor prognostic risk factors in patients. So cardiac MRI precisely does that. It gives us a risk stratification, and also it differentiates this particular condition from other causes which can mimic hypertrophic cardiomyopathy. It is also important in post-treatment follow-up in patients who've been already diagnosed and treated for hypertrophic cardiomyopathy. It also helps us in screening of family members because it is an autosomal dominant pattern of inheritance. So what are the highest features we talk about in cardiac MRI? That is, if there is a left ventricular outlet obstruction of more than or equal to 30 millimeters of mercury, or a mid-cavity obstruction gradients with more than 30 millimeters of mercury, end diastolic wall thickness of more than 30 millimeters thickness of LV myocardium, or a late gadolinium enhancement burden, that is a scar burden of more than 15%, or presence of a diastolic cavity obstruction, or presence of a biventricular hypertrophy. So in addition to left ventricular, also the right ventricular hypertrophy, and presence of heart failure, that is decreased ejection fraction of the left ventricle less than 50%, and also presence of apical aneurysm. These are all high risk features and poor prognostic features in a case of hypertrophic cardiomyopathy, and this is what exactly MRI plays a role in identifying these features in a hypertrophic cardiomyopathy. Now let us look at a graphic. This is from a journal, Radiographics, which shows us the different phenotypes of hypertrophic cardiomyopathy. If you can see, this is actually it can have a normal appearance also, but this is very, very rare. And most common and more important thing what we are looking at is a asymmetric septal hypertrophy, what you can see in this particular graphic, which is labeled as B. It can be basal septal hypertrophy, or a diffuse hypertrophy as in C, or it can be mid septal hypertrophy as in H. There are also other types of phenotypes of HCM, which can be a concentric type of HCM, or it can be a mid cavity type of HCM with apical aneurysm, or it can be apical type of HCM in what we are seeing in this G graphic. And sometimes it can be a burnt out variety where there is hypertrophic cardiomyopathy, but it has gone to a later stage where the thickening of myocardium is reduced and heart failure is set in. This is called as a burnt out type of hypertrophic cardiomyopathy, what we are seeing in E graphic here. And if you can see my pointer. And there are also milder expressions of the disease, which is it can be just abnormal papillary muscles, or supernumerary papillary muscles, or presence of myocardial crypts, which is this particular graphic what we are looking at in J. That basically deep crypts, deep like trough-like conditions within the myocardium represent myocardial crypts. So this itself can be an early expression of the disease. So we have varied patterns of phenotypes, which in which MRI correctly picks up the phenotype and also characterizes it accurately. Now, these are the MRI images, what I'm showing you in the next slide, where we can clearly see the different types of phenotypes of hypertrophic cardiomyopathy. What you can see in the first one is a asymmetric septal hypertrophy. This is the most important one. We can also see another patient with asymmetric inferior and inferoseptal hypertrophy. The third one is another patient with a positive gene mutation, but you can see very early changes of asymmetric septal hypertrophy. This is still a case of hypertrophic cardiomyopathy. Then in the lower row, what you can see is an apical form of cardiomyopathy, hypertrophic cardiomyopathy. Then you can see a mid cavity variant, which is abnormal insertion of the papillary muscle called as apicobasal bundle. In this type, there is abnormal insertion of the the papillary muscle towards the basal interventricular septum. This causes mid cavity obstruction and mid cavity gradients. So this is another important thing. As a radiologist, we have to alert the clinician so that this treatment for this particular apicobasal bundle is slightly different. That is, they have to reposition the papillary muscles rather than going for myomectomy or septal ablation. So therefore, in MRI, we should pick up this abnormal finding, which is not very common, but still it is present in case of hypertrophic cardiomyopathy, to alert the clinician the presence of this abnormal configuration of the papillary muscles. Then also we have milder expression of disease, like I said, where you can have prominent myocardial crypts in this particular patients, where you can see at the basal interventricular septum. So these are the different phenotypes of hypertrophic cardiomyopathy, what we can usually see in cardiac MRI. I'm going to touch upon little more in detail in all the different, more common different types of hypertrophic cardiomyopathy, where we can see this asymmetric septal type of hypertrophy of cardiomyopathy, where you can see that there is basal septal hypertrophy, which is encroaching up to the left ventricular outlet. So this causes flow acceleration and obstruction to the left ventricular outlet. Along with this, there will be systolic anterior motion of the leaflet, what you can see in the first image here. Normally, the mitral valve leaflet opposes to the interventricular septum in the diastole, but in this condition, because of the basal septal hypertrophy, it can oppose with the septum in the systole, and this causes LVOT obstruction. Along with that, there is a Venturi effect. So there is an eccentric mitral regurgitation as well. So there is volume overload in the volume overload in the left atrium. Therefore, in a chronic case of asymmetric septal hypertrophy, one can expect left atrial dilatation as well because of this eccentric mitral regurgitation jet. Now, coming to the late gadolinium enhancement within this particular condition, it is typically described as patchy mid-myocardial cloudy pattern of enhancement. So this is very important to differentiate between this condition and other condition which can mimic hypertrophic cardiomyopathy. What you can see in this particular image from a journal is that you can see patchy mid-myocardial RV hinge point or insertion point enhancement, and also there is mid-septal, mid-myocardial enhancement. So important thing is it usually spares the subendocardial layer of the myocardium. So therefore, if you see such a subendocardial enhancement, then you should think of alternative diagnosis. This is another phenotype where there is mid-cavity HCM, which has a relatively poorer prognosis, where there's mid-cavity obstruction and gradients, which causes stasis in the apical region. So in chronically, what happens is because of the microvascular obstruction, abnormal muscles, the apical region gets engorged with blood, and it is prone for scar formation, and there is thrombus formation, as in this particular patient where you can see a non-enhancing filling defect in the LV apical region. So this generally has a poorer prognosis. The mid-cavity variety of HCM has a poorer prognosis. Coming to the next variety, which is apical pattern of hypertrophic cardiomyopathy, what we can see is that this is typically involves only the apex, and it generally has a better prognosis than the other types of HCM. And if you can see, this has a typical spade-like appearance of the LV cavity. Okay, so this is another variety which has a relatively better prognosis, the apical HCM variety. Now, there is also a mass-like, which is less common, but a mass-like type of HCM. This has to be differentiated from a fibroma or any other masses of the myocardium. So there are different features in cardiac MRI, like the contractility, what we look at, the first pass dynamic perfusion, the enhancement patterns, and the T1 values. All these different factors help us to differentiate a mass-like hypertrophic cardiomyopathy from a fibroma, actually a mass. Now, what are the common differentials of these conditions? What we usually see is, more commonly, what we see is chronic hypertension can also cause left ventricular hypertrophy, but it rarely exceeds 16 millimeters. And usually, it does not show late gadolinium enhancement. So this is how we differentiate between hypertensive left ventricular hypertrophy and hypertrophic cardiomyopathy. And also athlete's heart. Sometimes trained athletes also will have left ventricular hypertrophy. Again, it usually, in this situation, how to differentiate from HCM is that the cavity also will be enlarged in athlete's heart, whereas the cavity can be obliterated in HCM. And also there is parametric imaging like T1 mapping and extracellular volume mapping, which can help us differentiate an athlete heart from a HCM. And also the enhancement is usually very uncommon in athlete's heart, although it can happen very rarely, but generally it doesn't happen in athlete heart. And most importantly, if you let the if you give a 3-month rest to the athlete where there is no training and exercise, the hypertrophy can come down by at least 5 millimeters in an athlete's heart. That's how, again, we can differentiate between a hypertrophic cardiomyopathy and an athlete's heart. And of course, more common conditions, valvular pathologies, which can cause left ventricular hypertrophy is, again, aortic stenosis. But again, this usually does not show late gadolinium enhancement, and the thickness is usually less than 16 millimeters. Now, there are other conditions also, like Dr. Sagar rightly pointed out. There are infiltrative conditions which can mimic hypertrophic cardiomyopathy. In these situations, we need other parameters within the cardiac MRI to help us differentiate HCM from other conditions. Like, if you look at the first image, this is amyloidosis. Cardiac amyloidosis also can have hypertrophic, left ventricular hypertrophy, and it can mimic HCM. If you see the top row, everything looks like HCM. But if you see the bottom row, the pattern of late gadolinium enhancement is quite distinct and different in all these conditions. If you see the first one, which is amyloidosis, you see both subendocardial and some epicardial enhancement. And usually the other features like difficult myocardial nulling or reversal of nulling pattern and thickening of interatrial septum and very high native T1 values in parametric imaging. These features differentiate amyloidosis from HCM. Coming to Fabry's disease, you can have typical inferolateral late gadolinium enhancement. Okay, you will not have the patchy cloud-like mid-myocardial enhancement what you see in HCM usually. And coming to Dannon's disease, also the pattern of enhancement is again different. It's continuous, and usually it is mid-myocardial but continuous. So therefore, this pattern of enhancement also helps us differentiate between different types of restrictive cardiomyopathies which mimic hypertrophic cardiomyopathy. Now, recently, there is a lot of work being done on parametric imaging, which is T1 mapping, T2 mapping, and extracellular volume maps, which is basically trying to see the native T1 and T2 values of the myocardium. This particular parameters in MRI help us even more, differentiating HCM from other conditions. For example, if you look at hypertrophic cardiomyopathy and amyloidosis, amyloidosis has a very high native T1 values, more than 1300, more than 1400. Whereas hypertrophic cardiomyopathy, you don't expect so much. So this is one important point which helps us differentiating HCM from other conditions also. And also in patients with a positive genetic mutation in HCM, if you do T1 mapping and if they're abnormal without late gadolinium enhancement, you can pick up the presence of replacement fibrosis within these patients even before the abnormal late gadolinium enhancement. So therefore it helps in early diagnosis of presence of fibrosis or a arrhythmogenic substrate in these patients with no late gadolinium enhancement. Therefore, parametric imaging, T1 mapping, and ECV maps have become a very important part and parcel of cardiac MRI to help us further aid in the diagnosis and differentiation between other conditions. So this is what I wanted to briefly convey on HCM. And if you want to, I think Dr. Sagar gave us a good idea about what the general treatment lines for this condition is. Usually they will stabilize the patient by medical management, and then if the patient is having any conduct abnormalities, they will think of ICD, or also if it is not amenable to medical management, then usually it will be alcohol septal ablation or a septal myomectomy finally. And let me just summarize what I've told until now. The role of cardiac MRI in HCM, that is hypertrophic cardiomyopathy, is mainly the diagnosis to accurately measure the wall thickness and to tell the exact phenotype of HCM, to risk stratify and pick up any poor prognostic factors, because there is a potential sudden cardiac death risk in these patients, and also to differentiate HCM from other causes, and to in post-treatment surveillance it helps us, and also because it's a autosomal dominant condition, in screening of family members, the cardiac MRI can be useful in detecting unsuspecting hypertrophic cardiomyopathy. So these are my references for today, and I hope the audience has found this talk useful on this particular conditions. And I thank you all for your patient listening. Over to the moderator, Dr. J. Prasad, sir. Thank you.
Thank you, sir. Thank you very much. It was an excellent talk, enumerating all the important findings in HCM patients. And over to you, Dr. Sagar, sir, your inputs and any questions you have.
Yeah, very nice talk, sir. And we are seeing now, we are practicing also last few years that every patient of HOCM should screen for MRI, not only for diagnosis, but also for the treatment modality. Because we'll know what type of HOCM we are dealing with, SAM, and if there is a specific sigmoid type and which is causing LVOD obstruction. And even after medical treatment, if there is a high gradient and patient is symptomatic, then we can take a decision regarding septal ablation if suitable on angiogram. And because on angiography only we have to decide, because if there is a very one large septal or multiple septal, then it is not feasible. Then we have to select surgical myomectomy. But if a patient is feasible, then yes, in expert hand we can refer the patient for septal ablation. And even after the treatment also, yes, repeat MR will help you regarding the efficacy of the treatment and the follow-up in that particular patient. So first important thing is, I think the diagnosis CMR is very, very important, because we should not rely only on echocardiogram, because sometimes we'll misdiagnose as restrictive cardiomyopathy as hypertrophic, and sometimes only a hypertensive heart or at least heart as a hypertrophic cardiomyopathy. And definitely if your diagnosis is wrong, the treatment, everything will be wrong. And selection of the patient for high risk for the sudden cardiac death, CMR will help. And we have to give counseling regarding the ICD, because that is the only thing which can prevent the sudden cardiac death. So CMR has to be done, I think, each and every patient of suspected hypertrophic cardiomyopathy. That is my. So it should not be underused. We have to do an MRI in every patient with SCM.
Thank you, sir. Thank you very much. Sir, Dr. Sagar, sir, one question from the radiology side. When we see these additional findings, sir, like apicobasal bundle is there, or a thickened papillary muscle, or a bifid papillary muscle also sometimes in HCM. So do they need any different or special intervention also?
Means hypertrophic papillary muscle?
Yes, sir. Hypertrophy, or there are bifid sometimes. We have variant, and or sometimes we have apicobasal bundle, which are accessory additional papillary muscles. So do they also need?
If it is not causing any mitral regurgitation or any obstruction or anything hemodynamic thing, I think nothing to worry about that. But sometimes if it is scarred, and that is sometimes the source of arrhythmia, and also that we have to see even on Holter and decide regarding that.
Okay, sir. Okay.
But first line, see, everybody should know the first line is the medical only. So we have to diagnose, do an MRI, put them on optimal beta blocker so that we can reduce the rate, and the LVOT obstruction will significantly comes down. Higher the rate, higher the obstruction, lower the rate, lower the obstruction. And sometimes we have to use even diazopyramide along with a beta blocker. And then in spite of medical treatment, if patient is symptomatic and high risk for sudden cardiac death, but genetically on CMR or any associated ischemia or any scar, then we have to consider ICD along with medical treatment. And again, alcohol ablation and all these are in refractory cases where in spite of medical treatment and dual chamber ICD and all, if still patient is having symptom, lot of obstruction and effort intolerance because of the exercise induced tachycardia and increase in the LVOT obstruction, then you have to consider either a septal ablation or a surgical based on your angiographic finding and sometimes contrast echocardiogram.
Yes, sir. Thank you, sir. Dr. Deepak, sir, one question in the chat for you.
Yes, sir.
Can we do cardiac MR in tachycardia when the pulse is more than 90?
Yes, sir. We can certainly do. It is a challenge for radiology. We have, as a radiology department, we have to cater to different types of patients with different physiologies. But like you said, even in tachycardia, more than 90 heart rate, we can definitely do MRI. But there are specialized sequences like free breathing sequence or a real-time cine imaging sequence in different vendors. These will help us to get a good image, diagnostic quality images without any distortion or an artifacts. But like in bradycardia, if it is less than 40 beats per minute, the heart rate is less than 40, the machine is not designed to do the scanning at that point. So therefore, bradycardia becomes a difficult thing where you cannot scan, whereas tachycardia, you can still scan.
Right. Thank you, sir. Thank you very much.
Yes.
Now there are no more questions in the chat. If there are no more questions, I think we can close the session. With your due permission, Dr. Sagar, sir, with your due permission, we will close the session. Dr. Deepak,
Thank
sir.
you, sir.
Thank you.
Thank you,
Thank
sir.
you for the excellent talk, sir. It was a really excellent talk. Thank you very
Thank you,
much.
sir. Thank
Thank
you.
you, Sagar, sir, once again. Thank you very much.
Thank you, sir.
Thank you. Thank you, sir.